get started with the main event here, I have a few little things to say. One is, I think we need to give a round of applause to Carol and Darlene, who have been to every one of these community compassion Beautiful. Let me also say a word about this library and compassion. There are most libraries, if you have a book that's overdue, you have to pay a fine, and you can't use the library until you pay the fine. And so what happens is that some low-income families, they've got a fine and they just don't use the library anymore. This library is different. There are also many libraries, if, goodness forbid, you fall asleep in the library, you will be, because maybe you're reading a boring book, or maybe because you just have no place else, or because you have no place else to go.
Jimmy, speak up. Speak up.
Speak a little louder.
Yes.
Some of us are old and don't hear very well.
Or because, either because you fall asleep, either because you're reading a book that's boring, or because you have nowhere else to go, you would be rudely awakened. That isn't the case with this library. They make sure you're comfortable, they tuck you in, and in the morning when you wake up, they bring you a cup of tea. Well, no, that part isn't true. But this is a wonderful library and a real symbol of compassion. And I would also like to single out someone else here. The marvelous Maria. The marvelous Maria Dominguez. All you have to do if you want to go to the main events in this town is just follow this woman around, and you will go there. And you will also be interested to know that thanks to Peter Elwell and Sarah and some others, we are going to have all of these conversations and many other things on the town website. A special compassion thing you can click on, and I think that's going to be really very, very nice. Now, is there anybody here that doesn't know about Compassionate Brattleboro and the Charter for Compassion? Anybody that doesn't know?
I don't really know.
All right, so who's going to tell Mark? Who's going to tell Mark, and what's your name?
Sue Friedman.
Sue. Who's going to tell Mark and Sue what Compassionate Brattleboro is and are joining the Charter for Compassion? Don't all put your hands up at once.
Your hand is raised.
Jim.
Okay, Doug, tell people.
The Charter for Compassion was conceived of and started by Karen Armstrong, a church historian, scholar on world religions, noticing that most of the world's religions, or I think she says all of them, understand the concept, do unto others as you would have them do unto you, and sees this as the basis for a compassionate world, and set the Charter for Compassion forward to encourage individuals and communities and governments and other organizations to become more compassionate. The town of Brattleboro signed on to this charter a year and a half ago, and Compassionate Brattleboro is a citizen initiative growing out of that to help the community achieve its goal. The town has said both 83% of the voters and the unanimous select board that we want to be a compassionate community. One of the things we discovered in this series is that we are a compassionate community. So the challenge becomes, how can we become more compassionate? So that is the work of Compassionate Brattleboro. One of the things we're doing is bringing these community conversations so that we can appreciate compassion when we see it in our community, and we can understand better what compassion means. to us, to our neighbors, and that it can then grow in our hearts and grow in our community.
Thanks. Thanks so much. If any of you are interested in joining Compassionate Brattleboro, here is the sign-up sheet. Sarah, let's put it right behind Sarah. And you will be, if you join, you will be joining the likes of Marie Proctor, who just walked in, and Sarah, and Patsy, and Anthony, and Scott, and Miriam, and Doug, and Lisa's honorary member. Okay, this is great. So tonight, we have another really super set of examples of compassion in our community, and this has to do with healing. This conversation, with active participation from all of us, will explore healing compassion that presently exists in our town. There's plenty. And the ways, we'll also have an interesting exercise about ways of presenting bad news. That's also a compassionate issue. And we're going to talk about and see if we can come up with some new initiatives that might make sense to pursue in our town relating to healing. Now, dear Agnes Mikijaniec is at the lacrosse game of her son, who's getting an award, so she might not be here for another half an hour, but this is her seat. Over here is Carolyn Taylor-Olson, that some of us call CTO, who is a Dr. CTO, was responsible for developing both the BMH, what do we call it? Hospitalist program, and the post-acute care department that cares for nursing home and assisted living patients. And so I think she needs no introduction. Neither does Dr. Bob Tortolani, who's been a family physician in this town for 46 years and counting, I would say, and continuing to teach first-year medical students at Dartmouth Medical School. So before we go any further, let's get on. Let me mention that although this is the last conversation of the spring, Carol and Darlene take good note of this, they will be continuing in the fall. And in the fall, we'll be focusing on such things as restorative justice and climate change and creation of employment for homeless people in our town. It's going to be another very interesting set of conversations. Okay, so we're going to begin with some opening statements, starting with CTO and Bob, on your personal definitions of compassion and how you have been able to practice compassion in your professional lives. You're on.
Thank you, Jim, and welcome everyone. What is compassion and healing? Anybody have a word to define this? I didn't think so. So, to paraphrase Justice Potter Stewart, it's hard to define, but I know it when I see it. It's a great phrase, by the way, if you ever, what he said. Now, 100 years ago, a doctor or a nurse would come to your house if you were ill. And what our profession had to offer then was fairly limited. But what our predecessors did offer was a kind word, comfort, and sometimes hope. They offered a presence for healing of mind and spirit, and maybe the body. It was more art than science, and I'm sure you've heard of medicine referred to as the art of medicine or the science of medicine. So, I went to medical school in the 70s at University of Southern California, which is in Los Angeles. And I chose that medical school out of the 4 that had accepted me because of the concept of treating the whole person, which just seemed right to me? Why would you not treat the whole person? We worked with real patients from the very first week of the very first year of my medical school training. 10 years later, when I was transposed to New York City, I read an article in the New York Times one Sunday that touted Harvard Medical School launching a new teaching platform that focused on treating the whole patient. And I've said this before, what arrogance, first of all. And I laughed. Now, in one of the earlier conversations that I had with Dr. Bob, when I first came to Brattleboro in the 80s, I learned from him that it was really at his medical school, under the tutelage of Dr. George Engel, and this is probably 15 years before USC adopted this concept of the whole patient, that this renewed concept of treating the whole person began there. In fact, with Dr. George Engel. Now, Bob had the privilege of knowing him personally. I only got to read his book, which was a little dry, to be honest. Anyway, so when did we stop treating the whole person? Because I'll bet that some of the bad doctor stories that you may wish to share tonight have to do with that feeling of disconnection from the person who is working with you to treat you for a medical concern. Well, I'm sure you have an answer for this, as I do. As technology has made advancements, some life-saving, some life-sustaining, some life-prolonging, the human care part of the art and science balance has actually shifted more toward the science and the technology. And while I certainly would not want to, and I don't think you do either, want to return to where we were 100 years ago, that scientific information is in fact vital and important to us, but we do need to do more in the medical profession about human touch and kindness while keeping our professional desire to take action and to look for healing and cure. There is now, in fact, some science showing that compassion can reduce systemic inflammation, leading to enhanced wound healing and other immune functioning. Compassion can also stimulate better patient adherence, leading to better control of disease progression and a shorter recovery time. So it's an evolving science, and much of that data is observational, not experimental in the true sense of the scientific method, where you have an experiment group versus a control group, but at least the question is being asked and pursued. Now, for me, there was really never a question about being kind to someone. I was raised that way. My parents were an example of kindness. So translating that to my relationship with my colleagues and with patients was not a huge leap. I also have taught first and second year medical students at Dartmouth. I did that for about 20 years. And I have to say that when they come in their first year of medical school, they're so bright and shiny, you almost have to wear sunglasses. But they want so much to make that connection, to find that human connection, that touch, the kindness, so that they can take the knowledge that they learn in the 4 years of medical school and then in their residency training to help people. And I have to say that that was true for all 20 of the years that I taught. Bob can reflect on his experience, but I think it's pretty similar. So there is some hope for the healing profession to continue both the art and the science. Did you want me to do a case, or, I mean, my own personal case?
Do you want? Sure.
Okay.
Sure.
Or did you? Okay.
Or save it for later.
Not that.
Whatever.
Not
Save it for later. Whatever
That's for later.
Like.
Special. I think one encounter that I had in my professional life, I'm now retired, by the way, after you've had 47 years, I had 37. We're about 10 years apart here.
Pretty close.
But we did retire in the same month, so.
That's true.
Was this one case that I want to share with you. So the names, of course, are changed to protect those folks and their privacy. But Mrs. Jones, at 73, was eating breakfast with her son. And her son had some learning disabilities, but he was pretty high functioning. But he, in fact, had lived with his mother all of his life. Mrs. Jones was 73 when I met her. She fell face forward into her bowl of cereal, and her son actually was savvy enough to call 911, and she was brought to the hospital one night. This was when I was working as a hospitalist, and I took the night shift. She came through the emergency room, examined, tests were run, and finally she came up to the intensive care unit. And what was very clear to all of us is that she'd had a massive stroke, one from which she would not recover. She was on a respirator, so a ventilator that helped her breathe because she no longer had the brain capacity to breathe on her own. But her heart was still beating. And her son came in, and of course he had all of the questions that you might formulate should this have happened to a loved one of yours. Will she recover? Is she in pain? And what do I do now? Now, my philosophy has always been, particularly when it's obvious to me in my experience and from talking with others who have examined and worked with the patient, she was not going to recover. This was going to be a terminal event. My own philosophy has been to always allow 24 hours before we start to talk about end of life or removing, sustaining respirator, that sort of thing. Because it's such a shock. People need time to, and 24 hours is not a lot of time, but it's enough time for them to have spent with their loved one now in this debilitated state to know that they, in fact, probably won't recover. And her son and I actually were able to have a very reasonable discussion because he really wanted to know what the steps were. And I give her a lot of credit because I think she taught him to sequence things in his life, which of course will stand him in good stead. But he wanted to know the sequence. And I tried to find the level of learning and vocabulary that would be the most meaningful for him. And actually by the end of that first day, I said, you will leave her with us and we will care for her. And I am here all night. But I want you to think about the fact that she cannot breathe on her own. And we will probably need to take her off of the breathing machine, which means that she will die. And he said, okay. And he went home with a friend. The next morning he came, and meanwhile I talked with the nurses, the social worker, the discharge planner, the respiratory therapist, the whole team of people who were involved in the care of Mrs. Jones. The next morning he came in and he sought me out right away and he said, okay, I'm ready for her to be taken off the breathing machine. He said, but I have one request. And it was the 11th of November in 2011. He said, I want it to happen at 11 o'clock. I mean, I'm going to lose it now, but it was a remarkable request. And one that I don't think he would have made if I hadn't been able to have the kind of conversation and, to use the word, compassion for the fact that he had some learning disabilities. This was, you know, the cornerstone of his life, this woman, and she was going to go away forever. That he was able to understand this, and somewhere in his brain, it was important to him that it was 11, 11, 11 at 11. And that's what we did. Everyone gathered around the bed, a few words were said, and at 11 o'clock we turned off the machine and she passed away peacefully. And to me, that's an absolute jewel in my professional life, of how to work with a family and how to treat a patient with compassion.
Wow, that's really good.
Okay.
So now I'm going to turn it over to my esteemed elder colleague.
Our buddy here. I was going to say 73 years old with a massive stroke seems pretty young, and
Yeah.
it is pretty young. She probably had an average of another 10 to 12 years to go. An average woman would be going about 84 years now. So I'm going to just say for all of us in the medical field, make sure you get your blood pressure checked, because she probably had a major problem with her blood pressure. And if you haven't had your blood pressure checked in the last 6 months to 12 months, get your blood pressure checked. No symptoms at all until you may have a massive stroke.
Fall into your cereal.
Yeah. Anyway, I can't help but think 73. You know, when we were 22 in medical school, 73 looked very old. You know, when you're 60, it doesn't look very old at all. And this woman had another 12 years to go, and she died prematurely because she probably wasn't aware of a blood pressure problem. Anyway, thank you very much all for being here. It says a lot for all of you to be interested in learning more about this topic on a very beautiful 74-degree May day. So thank you for being here. And Jim, thank you for asking me, and it's great to be here with Carolyn and Agnes, and it's an honor to be here with you. Carolyn mentioned very briefly that one of my teachers was George Engel, who developed the biopsychosocial approach, the whole body, look at the whole person approach to, I mean, that's always what I would think. Why would you want to treat anything other than a whole human being? But believe it or not, we divided people up into organs pretty quickly, and the biomedical model, without looking at the big picture of what makes a person tick, really didn't come along until the 1960s. So anyway, it was an honor to go to Rochester Medical School, which I think really taught a lot of us how to take care of our patients. I'm going to talk a little bit about my relationship with medical students and some of the challenges medical students have. I'm going to talk for a brief part about primary care physicians and the relationship they have with their patients, and some of the challenges they have. I have been honored to be a physician in this community for 47 years now, or 46 years. It's an absolute great community to practice medicine in. Not only are the patients nice, but we have great colleagues. The hospital is a good hospital. We have a good referral hospital. We have a lot, but when it comes down to the individual practitioner and how he interacts with his patient, that can be a challenge, and I'll explain that a little bit in a while. I'm going to talk a little bit about medical students, a little bit about primary care. I'm going to start with a definition. I'm kind of basic. I tend to go to Webster's dictionary, although I Googled it. One of the first times I've ever Googled anything. I couldn't find a Webster's, so I Googled it. And it's Webster's definition of compassion. Okay, his definition of compassion is a suffering with another, or a sensation of sorrow brought upon by distress or misfortune in another person. I myself don't see necessarily compassion as being something where the person has to be suffering, or I think that person can be just like anybody else, just normal person, but you basically care for that person. It's in my mind, it's a matter of caring for another human being or another living thing. We haven't talked about being compassionate towards anything other than a human being, but I think we can be compassionate towards other living things. I'm not sure you can be compassionate about, and you're talking about an inanimate object, but I think animals we can definitely be compassionate for. And as Carolyn said, sometimes it's a hard thing to define, but I think you can either feel compassion in yourself or see it in another and recognize it. And when I work with medical students, it's a great privilege to work with medical students, particularly in the first year. The first-year medical students are bright, they're excited. Honestly, they want to correct the world's problems. They simply are there to serve. And one of the first courses is learning how to interact appropriately with another human being. And that can be scary at first, but basically they're taught to be compassionate, or they're taught to use their tools of compassion because they start out all being incredibly compassionate. They learn how to go into a room, how to greet the patient, how to make sure the patient's comfortable, how to shake that person's hands if they are comfortable with that, how they wash their hands first, how they sit down at the level of the patient, how they make eye contact, how they try not to look at any devices, even their notes. Sometimes they need to look at their notes a little bit to ask the right questions or to remember to listen. We don't listen very well, but the most important thing is to make your patient comfortable, give that patient and you the opportunity to work together as a team and get the respect of the patient. The patient needs your respect, you need the patient's respect. The medical students have it in spades. But I heard one of the senior educators at Dartmouth Medical School, where I teach, say, you know, the trick is trying to make sure that the students don't lose their compassion. And I said, I didn't ask her at that moment because we're doing a lot of other things, but I did talk to her in the last month. And I said, you know, that was very interesting. I work primarily with first-year students, occasional interaction with second and third, but primarily first year. And she says, yeah, she said, you know, the students are under so much stress. The first year, you know, it's kind of a little easier for them in terms of a lot of extra nighttime duty, but they all have that sense of really wanting to be there and helping care for their patient. But something happens, a few things happen. They get very tired. They get very stressed because they have to get their boards done. They don't generally grade them. So it's very important to get honors in a subject. It's very important. They're always looking toward the next step, the residency, the internship, where are they going to live, that sort of thing. A lot of pressure, and the senior faculty member reminded me that when we went to medical school, piece of cake. And this woman, who is the senior faculty person, is at least 20 years younger than the two of us. She said that what they have to learn now is quantum different from what she had to learn, and she can't even compare it to what we have to learn. Now the good thing is the human anatomy doesn't change very much, but the rest of it changes, and there's a lot to learn, and it's awesomely difficult. There's also something very interesting called the imposter syndrome. The imposter syndrome is this. You're sitting next to two incredibly bright students next to you, and you're saying to yourself, God, should I be here? Am I up to this? Holy cow, can I do this? And I think we've all felt a little bit of this. I certainly, when I went to medical school, I said, oh my God.
I felt that way until I was 40, are you kidding?
These folks are so bright. But apparently 50% of women and 25% of men medical students develop this thing called the imposter syndrome, which creates a great deal of anxiety. They need to be reassured repeatedly, which we try to do as faculty, how well they're doing. And generally, they get better. But there's a tendency for anxiety, stress, fatigue, and oftentimes depression to get into the way of their learning and their abilities to interact with other human beings, their colleagues, their patients. And one of the things I want to say is you have to be okay emotionally, whether you're a student or a physician. You've got to be okay emotionally to really be compassionate and caring. Because it's very hard if you are suffering emotionally, either anxiety, depression, exhaustion. It's very hard to be compassionate. Compassion is there in every medical student, and we try, and she said it's very high early on, it goes down, dips in the second and third year, and fortunately by the fourth year things are better and the compassion is returned. And they even, believe it or not, they even are teaching compassion to some residents, because the residents, by the time you're in that training beyond medical school, you are so exhausted, it's hard for some people to really say, this is another human being as opposed to a case. We're never a case. We're a human being with something. We're not that appendectomy who's next. It's got to be a human being with appendicitis who needs to have her appendix out. Okay, that sort of thing. So anyway, that's the story with medical students. The good news is that medical schools are aware of this. They're trying to help it. They try to reassure. They've got this incredibly bright group of students that they're trying to make into great physicians who are going to take care of me and all the rest of us. And that's why we try so hard to help them to be good, because they're going to be taking care of us. So that's very, very important. And the nice thing is, it's an incredible group of human beings with whom to work. Medical students are just the greatest, and they do need reassurance because they tend to be questioning themselves, are they up to it? Now, the final thing I want to do is say that I've had the great privilege of being a primary care physician for my whole life. I went to that area because I care more about relationships than I care about diseases. I like diseases. I like to find out what that human being in my office has wrong, whatever it is. I want to try to listen well. I want to just try to be there. And I think that is compassion. That compassion is being there with all your attention, everything you can muster. We get a lot of experience over time, but if we honestly are not well enough ourselves, if we don't take care of ourselves, we cannot use the tools we have to help heal a patient. And so there's a saying in medicine, physician, heal thyself. That's a very important thing. We don't do a very good job at it. And what I'm saying is, I've heard a lot of friends say their doctors seem to be very tired. They seem to be not always looking at me. They're looking at their computer. They seem to be very rushed. And I say, you know, it's a very hard time right now to be a physician. We have terrible software. We've got a lot of pressures on us. We have employers maybe who are telling us we have to see more patients than we're comfortable seeing. We have time pressure. We're exhausted. We're working at night on the computer. It's not and I quite honestly am very worried about that. Personally, I'm worried about my profession. I'm worried about the abilities of my peers, of my colleagues to do the job they're doing. I felt very lucky that I was always in private practice. I could take as much time as I felt I needed to take. I was never told that I had to see a certain number of patients, and that for me was great. But the reality is it's hard, very hard economically to be in private practice these days. And many people are employed, and it is a very, very hard time for patients and physicians right now. And again, I'll go back to the fact, if your physician is either exhausted or he's tired, he's depressed, he's anxious, and we know that up to 40 to 50%, maybe even 60% of physicians at one time or another are feeling that way. They can't be what they want to be, which is there for you at all times. And I am just hoping things improve in our society so that physicians and patients have more quality time together. And we're working on that at higher levels to try to help patients and physicians, but it's one of the things that I'm bothered about now a lot. Okay, and I will just say briefly in terms of the specific cases. I'm a veteran. My experience in a war situation has been extremely important to me. It's affected me very greatly, and I care very much about fellow veterans. I think that I would say is when you're at your lowest, either physically or emotionally, and still can bring about compassion, I think that is where I see some of the most incredible things. I'll never forget going into the hospital. I was primarily with an infantry unit in Vietnam, but for a little while I was in a small hospital, and one of the men got pretty badly injured, and I went to his bedside. He had surgery, and I visited him, and I said, "Well, how are you doing?" He said, "Well, I just want to know how is my captain? Did he make it?" So he cared that much, and the picture of a nurse cradling a dying man, nothing more you could do but hold him and listen to him as he gave his last words. That happened over and over and over again with the nurses over there. If you ever find a nurse who's been in a war zone, give that woman a hug, that man a hug. It's amazing what they do. And that's the kind of compassion. When people are at their lowest point, they can still care that much about other human beings. It's really remarkable. So we have a good species. We have to keep working on it. I know you're a very compassionate audience, and I know that you won't ask us too many bad questions or big questions later. But at any rate, it's wonderful to be here, and I want to thank you all for being here with us. Okay.
The great advantage of having Dr. Bob as my primary care physician, and I want to tell you that in addition to checking my blood pressure, he also was checking in on, was I getting enough exercise, was I eating right, and did I have a smoke alarm at home?
That's right.
You mean he didn't ask about seatbelts?
I probably did.
Oh, wait.
And he's looking well, isn't he?
So CTO, you want to do your exercise?
Well, I don't know, should we wait for Agnes or not?
No,
You know, Jen, you think there might be a question or two right now?
Yes,
You know,
sure,
good,
please.
might be a good
Please.
idea.
Yeah, how would you distinguish compassion for an acute patient versus compassion for a chronic?
Yeah, go ahead.
Repeat the question.
So how would I describe or talk about compassion with an acute patient
They seem to be very different.
versus compassion for a long-term care patient? Is
Right.
that-
A patient you know is never going to get well.
Yes, okay.
But you're only managing the life path down.
So one of the really wonderful things about my career progression, if you will, is that I went from acute medicine to post-acute medicine. And in between was sort of office practice and chronic management. But for me, it wasn't really that different, except the speed in which it had to happen. So for the acute patient, for me, I would certainly want to hear the patient's story. If the patient were not able to tell me, then I would look for family members, friends, the rescue team, the police, whoever happened to be with the patient so that I could get a sense of the story. I'm a very touchy-feely physician, so for me, I always had my hand on the patient, which can give you an incredible amount of information. And I had one patient who found me several years after I'd gone to see her late one night, and she said, by the way, that night you visited me before I had surgery, she said, you put your hand on my forearm. And she said, it was the most calming thing that ever happened. And she said, it gave me great peace. So I don't really know when I have done something that was particularly meaningful, unless somebody tells me, but I always felt it was important to touch the patient. And yes, in this day and age, you must ask first, is it okay if I hold your hand or touch your arm or something like that? But it's about the speed. Now, the person who is failing, who is perhaps at home in hospice or in a nursing home with dementia, it's still the same for me. You put your hand out. In fact, I'm glad you asked this question, because I found that with my nursing home patients, particularly the folks who were demented, that the best thing I could do to help them was, in fact, to stroke their face or cup their face the way a mother would a child. It's amazing. I mean, the power of touch, of course, whether it's through prayer or whether it's I'm in a healing as a physician mode, is so powerful. And I think we often don't remember that, even within our own family structure. But I found that that was an important part of the compassion that I could provide for that patient who had no clue who I was and would not remember, but something deep inside, they would respond to the stroking of their face or cupping their face in my hands.
I'll just add about, in terms of the chronic patient, the person with a chronic illness, is that primary care physicians in general know that that's part and parcel of their role to help their patient, and to follow that patient through and never abandon that patient through his life, her life. And actually, it was one of, I know Carolyn feels this way also, is that was one of the real privileges and honor to be able to help a person as he or she was dying. And as a matter of fact, it's so important. You feel bad if you're not there with that patient at the end of his or her life. So anyway, that's one of the great things about, again, about relationship and about primary care physicians. We don't have enough of them, but those who choose primary care really know that's part of the role, and it's a role that they really enjoy, generally.
Did that answer your question, by the way?
Kind of, except that in the current medical disease management caretaking environment, where you have a highly fragmented care team, that the compassion level between members and across members, cross-disciplinary members, can be disparate.
Yes.
I think I'm being kind.
Mm-hmm.
I won't disagree with you, sadly.
So, and part of it is I guess this is a little critique, is that if what you say is true, and I certainly have no reason to doubt you about the training that you got, and what the training that the current medical students are getting, why isn't compassion in the core curriculum? Why does it seem to be an add-on? You know, what's wrong with the way we're educating doctors today, that we put them, that we teach them, or a byproduct of the way we teach them, is that they become less compassionate, even for a short period of time?
Well, that's
what is it that needs to be turned around?
You know, it's tough. It's an absolute. The educators are very well aware of that, about the fact that compassion is lost to some extent as you go through the educational process, and it again can be lost again if the physician or healthcare practitioner is having trouble himself dealing with the stresses he's going through. You have to be okay. And so how does one go through this medical education and allow these folks to be okay themselves? Because that's all they need to do to be compassionate. And as a teacher of medical students, I am constantly telling them, you've got to have balance. No one looks at your diploma to see whether you're at AOA. They only care if you listen to them. That's all the patient cares about. Our physicians are really well trained. The question is, are they okay themselves? And I encourage them all to do recreational stuff, to get enough sleep. You know, yeah, you don't get them all right on an exam, but you're going to be okay. And you know, we have a problem with our system. Everybody knows there's a problem. There are suicides in medical school. There are suicides in residencies. And one of the problems is you have extremely highly motivated human beings who are stressed out and really are worried that they're not up to the task. And our role as teachers is to try to help them be okay. And you know, we don't have all the answers. It's a problem.
I agree with that, but I think I need to say in Brattleboro that therapists have therapists, right?
We all have therapists. It's really, hey, listen, being a human being is tough.
Sue.
Yeah.
Sue.
Yeah, I'm wondering, for social scientists, compassion is a much broader subject. But in medical science, I wonder, you are defining compassion, or for that matter, empathy or sympathy in different ways, because it seems to be the medical profession itself, how you define what the compassion is about, and why it is sort of an add-on or instead of core quality to be excellent physicians. It seems to be, the way you're looking at it is quite different. And first of all, I'm just curious about, do you distinguish compassion and empathy and sympathy? Is it part of it or not?
Well, I think compassion certainly has a subset of empathy, but what sets it apart from empathy is the willingness or the drive to help. So it's empathy plus helping, if you will, to be terribly simplistic about it.
I think that's what the social scientists believe it too. But I always find it, my personal experience with the PCP would be, if anybody come in contact with me with the extra thing, that little extra empathy or compassion, that makes all the differences. But yet, it is more exception to the rule. They are rushing into it and just done and give you prescription and done. But I find that they don't seem to know the difference. The older people I met so far. And I always say, look, I don't know what your training is. Was something wrong with this process? And they were kind of surprised that they did it.
Well, there are many external pressures, obviously, but I think it's the same for any human service profession, whether it's pastoring or teaching or social work or even judges, that you know compassion when you see it, you know compassion when you feel it, and it happens in all of our interactions with each other. So it's something about a human connection that says, oh, I see you're hurting, let me help.
Jinsey.
Well, actually, my question must have been answered because it was seeming to me that the most important thing would be to forgive yourself first, because you're
Yes.
not going to be perfect.
Yes.
And
Learning you're not
going to be
perfect.
tired, and sometimes you're going to be cranky, but
Yeah.
forgive yourself and keep on. I think that in any walk of life or any way of living, it's important. It's the most important thing we can do.
That's right.
Mel and Doug, let's hold off, I think, if it's okay, and do our exercise.
Okay.
And then we'll have more opportunity for conversation.
So when did you print something out?
Oh, yeah.
Oh, okay.
And I've got 2 more copies.
Okay. Oh, well, I'll give one to Bob here.
Okay.
So we wanted to, for those of you who, and I don't think that really includes anyone in this room, but you may have recalled from the news there was something that was reported where a patient received bad news through a telemonitor with a physician. Does anybody recall that story? Okay.
What's a telemonitor?
Well, you know, it's like Skype or FaceTime or something. So the doctor wasn't in the room, but he gave the patient the bad news that way. So this is a demonstration of the less than compassionate way to give health news. And it's to a telephone machine. Hi, this is Dr. Jones, and this is a message for Jane about test results she had done this morning. Jane, it's not good news. Looks like you have leukemia, which you probably know is cancer of the blood cells. Call the office and make an appointment, and we can discuss the situation if you have questions. Take care. Bye-bye. Now, if you came home worried about your test because you hadn't been feeling very well and you went to the doctor and, you know, had some tests done and got that on your answering machine, how would you feel?
I'd take a gun and go shoot it.
Okay.
Go shoot him.
Go shoot the doctor.
Go shoot it.
Well, the other thing is, one of your kids could come home first and turn the answering machine on, just thinking it's a message for them.
Good point.
Right.
Good point, yeah.
Any other thoughts? How did that make you feel?
Well, the thing when it said, if you have any questions, I mean, of course you're going to have questions. And you want to talk to somebody immediately, a person. People really do that.
Is that a thing?
Well, there was this news report. That's why I made this so specifically a script.
Isn't that a HIPAA violation? I mean, I thought they didn't do that sort of thing.
Well, you know, there's HIPAA and there's HIPAA.
Well, yeah, but this, I mean,
Well,
you've got the smoking gun there.
Yeah, I mean, if the answering machine said you've reached Jane, that's one thing. If the answering machine was one of those, you know, robo voices that said you've reached, you know, whatever, I of course would never leave a message like that, but I think some people have.
And sometimes they ask you if they can leave a message.
Yes, but in this case,
Right.
we'll assume that they didn't.
Also, what I responded to right away was the flip nature of, also the, take care.
Bye-bye.
Take care, hope you don't die before we talk to you, take care. Have a good day, have a nice day or something. Which is really very often done with that disconnect from compassion.
Yeah.
When they're in med school, is this something that they're ever spoken to about? Like, I mean,
Yes.
the way you should.
Yes, and the next script I'm going to read is
Okay.
a better example of a more compassionate way. And this is a face-to-face encounter. Does somebody want to play Jane by any chance? It would be nice.
I'll be Jane.
Would you like to sit
Who
here?
wants to be Jane?
I'm Jane.
All right. Thanks for coming back to talk to me about your lab tests, Jane. The results
I'm
show
worried.
you're worried.
Yeah.
I understand that. The results show that you have leukemia. And this is a cancer of the white blood cells. There are just too many of them being produced.
And leukemia die from, right?
People have died from leukemia, although there are treatment options. And that's the good news, is that we have an answer that helps explain your tiredness and your achiness and the fevers that you came to see me about the other day. And we have ways to treat leukemia.
And I'll feel better?
Yes.
And I'll be cured?
Cure is one of those amorphous thoughts, but
What does amorphous mean?
oh, a kind of foggy, not clear.
You picked the wrong person.
I know you. This is good.
Well, that's exactly
So,
something you might say.
I'm taking this condition very seriously, and I want you to take it seriously. I've called Dr. Green, and he is our hematology oncology specialist, and he can see you this afternoon at 3 o'clock in his office, which is down the hall, and he's going to help us with next steps. There may be a need for more tests as well. I know this is a lot to take in. Is it possible for your daughter to meet with you and go to see Dr. Green?
Yeah, somebody, I wouldn't want to go alone for that.
I think that's wise.
Because I'm already anxious about it, and now I'm not even thinking clearly because of this news.
Exactly. So I'm also here to walk through the next steps with you. What questions do you have for me right now?
A lot.
Anyone that rises to the top at the moment?
How long do I have?
Good question. And we're going to need Dr. Green to help us with that. So I can't answer that specifically right now. And sometimes that's actually not a helpful number or a helpful piece of information, but let's move forward and take the steps the way they should be.
Chemo or radiation, do you know that, or is that another question?
Probably
for-
chemo,
Yeah.
and the good news is it can be oral as opposed to IV, but again, we'll need Dr. Green to tell us what he feels would be the best thing for you. Now, once you and your daughter have met with Dr. Green, I want you to take time to think about what he recommends, and you may wish to talk with the rest of your family about this. And then I want you to come back to see me and tell me what you heard, what the plan is, and I'll be waiting for your call.
Thank you. Do you have something written that I could
Yes.
take with me?
Yes, I
and
do.
Get educated on and.
Yeah, now, don't get scared because this information is very general, but again, you're going to see Dr. Green this afternoon, so you only have 3 hours to be anxious and nervous.
Can I stay in here with you?
You
And
certainly
you'll talk to
could.
me for 3 hours?
Well, you can sit in the waiting room and we'll wave at you guys through the window. Thank you.
You did great.
So, thoughts, comments?
While we're waiting, oh!
He's
Look
here.
who's here!
How was the award ceremony? Great. Welcome.
So proud of her.
Oh, wonderful.
Oh, okay, okay.
All right, we moved from
Yeah,
Agnes
sure.
to between us.
Sure, good. Okay, with Agnes here, let me just quickly read a couple things. One of them is about a Dr. Raphael Campo. That's an article about his compassionate care, and if any of you are interested in reading the article, I have the link here. But just let me read a bit of that.
Speak up.
Yes, when Dr. Campo sees patients, it is without clinical distance or emotional remove. Campo was fully there with what he calls his authentic, complex self. it has become a conscious part of his approach to be more vulnerable and open in clinical encounters. With patients, as with everyone, he is the physician, but also the poet, the gay man, the Latino, the striving second-generation immigrant, a husband, a brother, a person possessed of all his memories and knowledge and feelings, imperfect but fully human. Patients, he's discovered, find comfort in that. They trust it. There's an empathetic understanding that allows us to get past the 5 or 10 throat-clearing questions that aren't really why the person is here in my office at that moment, he says. That sense of, we know each other. We're together in this experience, partners, as you just mentioned. The sense of we know each other, we're together, in some ways allows me to be a better listener, certainly, but also a better physician. And some of you know that our Compassionate Brattleboro has been publishing in the Reformer and in the Commons a compassion story of the month. And we are welcoming compassion stories. I'm sure you've all got them. A few of the people that had an idea were from the Oncology department at BMH. And let me just let you guess who they wrote about. So I just want to read just a couple of sentences. And I think this describes Agnes so beautifully, but also I think all 3 of these wonderful people. Agnes is a gift, says one of her former patients. She responded to every one of my visits and calls as if I were her only responsibility. And another patient said, she took such wonderful care of me. She made me smile. She educated me about my illness in a way I could really understand. I called her so often, and she treated me as if I were her dearest friend. Whoa. Whoa. So, Agnes. If you could talk to us about your personal understandings of compassion and how you've been able to practice compassion in your professional life, and give us one illustrative episode of compassion from your own experience.
I'll make it short. I mean,
I have, by the way, that compassion story as well as the Harvard things, if anyone's interested.
Compassion, from my perspective, is empathy, but with the willingness to act on it, essentially. I brought a quote because I thought I'd make it short and sweet. And I keep this in my office right above my screen, so when I'm feeling like I've got way too many things to do and that my kids are going to kill me because I haven't gotten home in time, I use this. And this is a quote from Maimonides. May I never forget that the patient is a fellow creature in pain. May I never consider him merely a vessel of disease. And it sits right there, and it's my reminder. So that's what I have to say about compassion.
Absolutely.
Wow.
Absolutely.
Wow.
It's a great little...
Could you read that once more, a little bit louder?
Sorry. So may I never forget, this is Maimonides, one of his prayers, who was a philosopher, I think, back in 1200. May I never forget that the patient is a fellow creature in pain. May I never consider him merely a vessel of disease.
Wow.
Jim,
Yes. Do Do you want to give us a story of your experience, and then we'll get some inputs?
So, as a nurse practitioner, I come from the experience of being a nurse first. So, I had the opportunity of being an AIDS nurse back in the 90s when it was actually a really terrible plague, and I think that really formed a lot of my experience as a nurse practitioner in oncology. I worked in Mount Sinai in an AIDS unit around 94 to 97, and I took care of hundreds of patients. And there was one particular patient whose name I don't remember, and I had gotten a report that the patient was a 23-year-old Latino, history of IV drug abuse, had cryptosporidium in the brain, was having a lot of swelling in the brain, was what they call locked in, which means he couldn't communicate in any way, but probably was quite coherent. And you can tell because they can blink at you and answer questions appropriately. Had an episode of bleeding of the bowel. He had a gastric ulcer from steroids trying to control the swelling. I walk in and I'm told that the tests that they did showed the bleeding, that there wasn't much else they could do, and that I was supposed to try and transfuse him and see if he would stabilize. I walk in, he looks at me, I can see that he is likely going to die soon. His heart rate is really high. I can sense that he's bleeding. I go to the intern, she says, and I say, I think this guy's dying. We need to do something and redirect her plan of care. And she's like, no, you can't do that. These are your orders, and you have to just continue with what I ordered, or there'll be repercussions. There was no conversation. And you know how that goes. I called his mother, and I told her that I felt the patient was dying. And then I went back in the room, had given a unit of blood. I turned him over, and he was exsanguinating, which means there was bright red blood going out faster than I could get it in. And it was actually now starting to drip over the bed onto the floor. So now I'm in a room with a 23-year-old, I think I'm 25, who I cannot quite tell him that I think he's dying. His mother comes in, and she's one of the IV drug abusers that is actually pretty well known in the area. And she basically looked at him, started crying, and walked out. Probably couldn't handle it. And my nurse aide walks in, starts disparaging her, and I said, just, let it go and please leave, because it's not what we need to be doing here. And I was also worried about her because I had HIV-infected blood that was now spilling onto the floor. And there was this moment of real anger and real frustration because nobody was helping me. Not mom, not physicians, not anybody. And I just decided to close the door and have my other nurse take over my shift. And I stayed with her, and I didn't really say anything, but we looked at each other, and I let him die. And he died within the hour. And I waited another 30 minutes before I called the doctor, just to make sure that she wouldn't do anything excessive. But I think those series of just being with somebody and leaving, letting things be as they are, but just being with them is what really helped.
Mel and then Doug?
I feel that the key overriding value in much of what we've said, compassion and other stories, is what I call connectedness with the other. That is to say, having a unity relation experience with the other. Once you start to feel that, then many things develop, including compassion. So if you meet somebody, or not a bad way, perhaps an alternate way for a doctor to meet a patient, is try to establish connectedness with the other. Oh, didn't I see you fishing over at that pond the other day? No, it wasn't me. In other words, some common ground which you start to feel connected with the other. Then a lot of the wonderful things that we've been saying, including compassion where it's needed, will follow. And the door is open. When you're connected with it, it's an open door with you and the other person. That's what I recommend.
I think it's probably fair to say that most of us who've gone into primary care will say that what we love most about it is hearing the patient's story and finding those connections. I mean, we all have enjoyed a longevity of a relationship in our long practices with patients. Would you say, Bob? Your stories are so important to know and to hear. I don't know, I really don't know how much of myself I told to patients. But there are some who I knew for many years who clearly knew about me, my son, and the fact that we both sing, and you know, he's now in Los Angeles where I don't want him to be, but oh well, you know. But there are things that we know about each other, and it's not so much that we're friends, but we're connected.
Yes, that's right.
Nice.
So I think if you think in those terms, connectedness with the other, try to establish it, it's also often reciprocated almost immediately. Then a lot of the other things that we've mentioned, including compassion, come under that umbrella.
Doug.
I want to back up a little bit to Bob's non-definition of suffering with, and also the important point that we need to take care of ourselves in order to be able to be compassionate and to act on compassion. So to be suffering with, you're in a position often when you are working with people who are suffering. It was interesting when Chief Fitzgerald was talking with us about policing and how important it is to have officers who are compassionate, so that when they're dealing with people, they are with them. And I think part of this same thing, can they understand the feeling? So if you are with someone who is suffering, how much are you able to enter into that suffering and take it into yourself? You're also in a place where you have seen a lot of suffering and you understand what is going on inside the person. How much do you allow that into your life? How much do you allow it into your person? And how do you relate that to being professional, to maintaining the bedside manner of kindness and respect and patience, and how do you take care of yourself when you are in the presence of that suffering? That's for all of you.
Those are really easy questions, right? Terribly difficult. Pretty basic. You know, I'll tell you, it's a very tricky situation. You cannot help but feel the suffering of your patients. On the other hand, you really have to protect yourself against getting too involved, because it's too painful. This is where kind of professional boundaries occur. I sort of never liked it when I had in my practice people who were friends, close friends. I tried to avoid that. Some of my patients became friends, and that became difficult because I would possibly be in a situation where they would be very ill and I would be dealing with that. For me, it was impossible to not get involved, both in what patients do, what their families are doing, the connectiveness, and their suffering. But at the same time, I had to protect myself from getting too involved, or I would not be able to take care of the next patient. I would have to be careful that I myself had integrity, that I was taking care of myself emotionally. So I can't be grieving all the time. You can certainly be feeling and caring and doing everything you can professionally. And I'll just say, as an aside, in the military, I had to be careful about getting too close to people because they died quickly in the military in a combat situation. So I had to put an emotional barrier on people that I might otherwise become friends with in a military situation, because so often people were suddenly either badly injured or died. And if you were close to a lot of people, it just became overwhelming. It's overwhelming. So a lot of your veteran friends may have gone through the situation where that same thing happened, and that causes problems and possible problems with later relationships, because they've seen relationships end quickly, and they're always worried about that. Something to keep in mind. But anyway, you bring out a very important issue about the issues of how can you protect yourself from getting too involved. You have to get involved. It's natural that you're going to get involved emotionally, but you've got to protect yourself from getting too involved. And I think there's that fine line. Each person works it out for himself to find out what's right for him. We're all works in progress, we're all learning. But I think, just as Agnes said, just being there for your patient is crucial right through their life.
In the time that we have left, let's do this. Some of you may have additional questions, but let's also think about and offer some ideas about what we'd like to see Brattleboro do to support compassion relating to healing. So this is for all of us, and for Bob and Agnes and CTO. Please.
As a nurse working on the floor at the hospital, one thing that people in the community can do is really respond to those questionnaires that come home that sometimes we just throw in the recycling, and really even mention by name those people, and nurses, housekeeping, whoever it might have been that took care of you, that did that, so that credit is given also, and so that people are aware that we are really prioritizing this. I go into rooms almost every single day with an oncology patient, and they say exactly what you just read about Agnes every single time. And I tell the story that I became a nurse because I wanted to be like Agnes. Wow. That's true. When I asked her to hire me, I keep putting the pressure on. I asked her to hire me. I need a little more experience, but even though I'm old. But that, one of the things that happens also in the hospital that I make a point of doing with families, besides the touch, and I'm guilty of, I do not ask every single time. I have a 6-patient load, and I'm going in and out of that room, and is it right if I do?
You got a little time?
I very often will just lay my hand on and do that. And people have commented on it, and it's a little tricky. But one thing I always do when families are leaving the hospital at night, and they're worried, and they're leaving, they're not allowed to stay over, and they're leaving the care of the person they love most in the world oftentimes in your hands. And I always try to say, as they're heading for the elevator, we'll take good care of you tonight. We'll take good care of her tonight. All right, and I've gotten so much feedback from people afterwards saying how important it was to know that the care that you can't give as a lay person, you're putting in the hands of the doctor, the professionals, to really take over. And it's not just for the science end of it. It's really for the loving compassion. And I have to add humor into that, because that's one thing that I always bring into the room also with the connectedness to other. There's almost always, you can find a little way to get in there, and I think there's a lot of healing power in that also.
That's great.
Well, that really resonates with me, because trying to convince our primary care group to give over the care of their patient to a hospitalist service. Now, do people understand what hospitalists do? So they're in the hospital 24/7. They take care of patients who are in the hospital. And the traditional model is that your doctor, Dr. Tortolani or Dr. Taylor-Olson, would also take care of you in the office and take care of you in the hospital. When the hospitalist system began to evolve and to grow, that separated the outpatient from the inpatient. And it was an uncomfortable transition for many. Bob was one of the last.
Yes. It was hard for me. I didn't want to give up that.
No, did you?
Patient.
He did,
I did.
ultimately. Before I left, I had 100%. Anyway, participation. But anyway, one of the things that was important for me to say to the patient and to the family, because I worked mostly nights, was I'm here all night.
Yes.
And that was a very comforting thing to say to the family, to the patient. So I didn't mean to jump on.
And Carolyn, it made it easier for us to give it up knowing that a person like you was there.
Thank you, Bob.
Please. It strikes me that one of the things we can do, Brattleboro is an amazing place. This initiative is wonderful, and these people are incredible. And one of the things I think we can do is thank them. And I sense that they're pretty modest. So just a quick story. Some of you may have known Joanne Nichols, who was a good friend and had cancer and was at Dartmouth. And so I went up to visit her probably 3 or 4 days before she died. And she wasn't in a good place. What she said is that they'd opened her up and that the cancer was everywhere and she had very little hope. And so I felt terrible about that. But I noticed she had this teddy bear. And Joanne wasn't a big person, she's a pretty small person. The teddy bear was almost as big as she was. And I asked her where it had come from. And her whole demeanor changed. She brightened up, she had this beautiful smile. She said, Dr. Tortolani.
Yeah, he was very big on teddy bears. And then they got rid of the gift shop and cut off his supply.
Thanks for that story. Yeah. They're very nice to hug when you don't have anybody else to bed with you. They're very sweet. Thank you.
Please.
Two things. One is I don't know if this is the right place, but I would like if the hospital could expand their services. I have a dear friend who has wet macular degeneration. So in order for him to get treated, we have to go all the way up north, which is over an hour, which is very challenging in the wintertime here. So I'm having a hard time bringing him here. And I know there's a number of people in our community that have this condition. I don't know who to talk to about maybe bringing someone to either our neighborhood or to Keene, but I know the doctor that he uses in New Jersey was actually trained at Brattleboro Memorial Hospital. So that's just one thing. If anybody has any ideas they could share how to maybe get a clinic or a once-a-month clinic here, that would be really great to treat this condition. The other thing is I'm really grateful to have met Agnes. She's been my oncology nurse a couple times, and the thing that I felt that was so compassionate about her was that you just felt like she looked at you like you were just as smart as she is, and I'm sure that's not the case, but she also is very educating, and I really appreciate somebody just telling me everything I wanted to know about what was going on. So thank you.
That's very nice.
Wow, wow, wow. At the last session, we asked the question, this was about town governance, we asked the question, they were talking about the fact that their process is to think big and outside of the box, and then you got to rein it in according to the budget that you've got, right? So we asked the question, what would you do if the Gates Foundation just said we want to experiment with Brattleboro and give you so many $1 million and you can think out of the box, what would you do? And the chair of the select board, what's her name? Brandy. Brandy said, well, here, I've got an idea, she said. Right now, people with opioid addiction, which relates to healing, there's a kind of an opportunity for 21 days of treatment. What would happen, she said, if we had a campus where people could be not for 21 days, but for 12 to 24 months. And the campus would take you all the way from supervised injections all the way to semi-autonomous living with nurse supervisors. And the question came up not because of the Gates Foundation, but because of the Sackler family that owns Mount Snow. The Sackler family of Purdue Pharma and OxyContin. So the suggestion that Brandy made was, what would happen if somewhere on their very large property they set up such a campus? And one of the responses is that Brattleboro is a very compassionate town, but Brattleboro doesn't have unlimited patience for people who cause suffering of others in the interest of making a profit. Other thoughts and comments and suggestions? One, two? Lisa, go on.
No, go Lisa, you haven't said anything yet.
Well, I would like to echo what other people said about these three people, that if I have someone who, I'm a pastor, if I know that someone is in one of their hands, I sigh I really sigh relief and gratitude. So I just want to say that out of the box. But there's another piece that I think hasn't been expressed that I would like to also say also as a thank you, is that my sense of Dr. Tortolani and Agnes in particular, and to some degree Carolyn, but I haven't overlapped with you, is that compassion, if it really is listening, leads you to a step that you might not have thought of otherwise. And I think one of the things that I've recognized in both Dr. Tortolani and Agnes in particular is that they listen deeply enough that they pull from all the knowledge that they have something that another doctor who was moving faster might not have come up with. And I feel like it's not really fair to have compassion be mushy. I really feel like compassion is the kind of listening that actually gets to the place where there's actually, it moves things into a place of healing that might not have occurred otherwise. And I just even listening to you, I remember that. And I've seen that, you do that in the I'm looking at Carolyn now, in with the elderly, that it wasn't necessarily pushing the person, it might have been pushing the nurse, you know, to listen in a deeper way, so that what if you did such and such with that patient? I think that's where, as somebody who cares about the people you've been working with, I've been so grateful, and I just want to say that part, because I do think it's an active, not entirely passive listening. It's one that takes you to act. I've said it now 3 times. So
Thank you.
I'm Cissy Lofton. I'm a retired social worker. And one of the deficits I see in the hospital is the lack of social workers. I know the jobs that social workers might do are divvied up between case managers and other things, but I think it's a real lack of focus that somebody who looks at the whole family, the whole system, cares about the practitioners, worries about their stress. And I make this every time I have a chance to talk in the hospital. Oh, do you have social workers? No, we don't. Lots of hospitals do. Well, we don't. Yeah. So if any of y'all could take that back.
There is a chapel.
There is?
Yeah.
It's
next to the Tyler Conference Room.
Chapel, not chaplain.
Oh, chaplain. Sorry. There is a chapel.
Yeah, no, I know.
Okay.
Yeah, that's another place that kind of compassion could happen. Social workers, chaplains.
I really agree with you about having social workers that kind of take it the next. As you can tell, I'm all about
there are times
taking.
where I'm lost and cannot figure out what to do, because I do not have that. I have a lot of clinical skills, but the psychological distress or the family dynamic crisis that sometimes happens, I really miss having the ability to page a social worker.
Volunteer social workers.
Thanks for bringing that up.
And chaplains. And when I worked at NYU, and they had a chaplaincy residency, so we had a chaplain on floor.
You were there when I first started. We had a rotation. And there was a chaplain, and you could call day or night.
And I often did.
Yeah.
I think the chaplain still has a parking space there.
They do. I keep wondering, does anybody know that you're not supposed to
Give me a parking space and I'll come.
An interesting story along those lines. Some of you know that Brattleboro now has 4 sister communities. One of them, thanks to Lisa and Guilford Community Church, is Wangari Maathai's village in Kenya.
That was wonderful to hear.
And another in Haiti, another in El Salvador, and another in a slum area of Calcutta.
Yeah.
So, and that's one where my son's program, Calcutta Kids, has been very active. So that program in this slum was able to reduce severe malnutrition from 13% down to 3%. And Noah asked, why can't we get it to 0? And so they did a careful study of that 3%. And what did they find? Every one of those kids came from a family with dysfunction. Alcohol dysfunction, spousal abuse, some kind of dysfunction where the kind of health and nutrition interventions being offered were not sufficient. And so Noah picked that up. He ran off and got himself a degree in social work on top of public health. And he has incorporated this social work activity into the regular set of activities done by the community health workers. And the community health workers are so grateful. They said, we are having to deal with these problems so often that finally now it's become part of our job stream. Really good, really good. So we have one more comment? Or
just
question?
wanted to follow up on this. Are physicians and nurses the only place where compassion enters into the medical system? And in this case, I think we're talking specifically about the hospital, is what we're talking about. And I'm curious about your perception of how important it is that that compassion comes from the physician or the nurse, someone providing medical, and how possible is it for compassion to come from a social worker or a chaplain and serve the same purposes in terms of supporting healing?
I think all of the healthcare team, and I've always been someone who thinks the team is a circle as opposed to a triangle, which traditionally had the physician at the top. But the person who comes in and mops the floor in your room, the person who delivers your food tray, the person who picks up the trash, who's different from the one who mops, by the way, the nurses, we don't have social workers, but the case manager, these are all important people to the care of the patient. It is a team. We often would meet as a team to talk about the plan or new results or something like that. So the pharmacists, I don't want to leave out the pharmacists because they're pretty key. And I think all of these people understand the connectedness part of taking care of a patient. I've had patients say to me, I really like that housekeeping person. She asked me about my dog. You know, and who is taking care of my dog? I mean, I think it does involve everyone who works at the hospital. And I think people who work in a hospital have a special affinity for that.
How about for the last comment?
Okay, good. Good,
Oh, Tom. All right, Tom. We'll give you one too. Go ahead.
I wanted to speak to the compassion fatigue. We call it compassion fatigue in with the nurses, and I was happy you mentioned the opiate crisis that we have right now, because it's really huge in our area, and we're not, I mean, I know we're addressing it in some ways, but I've seen over and over again many people in the medical community, as we have the same situation happen over and over and over again, that it is compassion fatigue, and really nurses, doctors, it's really hard to keep up it's a little different than what Dr. Tortolani was saying, because you were saying, and this happens of course also, the suffering and the pain, and hopefully with every person, whether they're an IV drug user or not, you are able to find that connectedness and that compassion, and it's really, really hard sometimes, and we have to address it better, because we're really it's a crisis.
Thanks for that hard work you're doing.
Tom. Thank you.
I just wanted to make an observation as I sit here this evening and having attended all of these presentations, which I found very rewarding and interesting to find out. But then I look around this room, and here we are in a town which is a city that's compassionate. And I look around this room and say, are we representative of this town? How many of us in this room are under 30 years of age? These are the people who are going to make Brattleboro compassionate. And it's very good to talk about what is needed and what is cared for, but where are we going to get the representation of the younger generation, the Noahs and so on, who are going to make this town compassionate?
Take away their cell phones.
When Tom,
Well, they're at their kids' games.
when Tom and I were around
Now we're
30, he and I were both working in India together on public health and nutrition. So we were under 50.
Yeah. So where are the 30-year-olds?
Yeah.
Why aren't they coming
Mark,
to these meetings?
you got a job here.
That's
Yeah.
something we have to.
It's a very good
question.
We have to ask ourselves. Why are we not
Tell me
attracting these people?
When you got a call to go to the hospital.
Oh my
I
God.
think that would be a perfect.
So this is about pastor stuff, right?
Yeah.
And I guess maybe there used to be, or there still is. When you check in, you can mark down whether you would like to be visited by a priest or a minister or rabbi. Does that still happen? So I got a call a few years ago from the hospital saying there was a woman who wanted to see the rabbi. And I hopped in the car and zoomed down to BMH, and I hustled over to her ward, and they pointed me to the room, and I went in, and she's sitting there, and I introduced myself, and I said, well, tell me, what can I do for you? And she said, well, when I checked in, they said, would you like to be seen by a priest or a minister or a rabbi? I never met a rabbi. So let's give a round of applause.